and in the community. And our community members, our patients, are going to have more knowledge about pregnancy and about the postpartum period, about interventions, about natural birth that they can use themselves to better their own outcomes. So what I love most about this program is that the patients themselves are taking their vitals. Sometimes when you show up to a visit, no matter where it is, but especially in the prenatal period, we kind of, everything is done for us. So we show up, somebody takes our weight, our blood pressure, listens to the baby, and they kind of direct us and tell us what we hope in this model of care is that our patients will become more involved in their care and more invested. And that's what patients want. Patients want to do the best thing for themselves. They want to be involved in their care. So our patients are going to learn to take their own blood pressure, to take their own heart rate, to even find the baby with the Doppler oftentimes.
Oh, wow.
Yeah, to figure out kind of how their belly feels during different parts of pregnancy, to be aware of themselves. And then that also makes them more aware of warning signs or bad things that could kind of happen. So this is going to be really, for our community. It's just going to be better for them. It's going to empower our patients instead of taking that from them by doing their own vitals and doing everything for the patients. So I think overall it's going to improve our care, like Hillary said, improve our outcomes and just make communication better for everybody involved.
Right. It's kind of, to me, seems like it's a higher quality, but kind of higher end form of prenatal care. It's not just your run of the mill, what everybody does everywhere. It's very unique and specific and tailored to the patients, and you kind of get your group of people to go through the journey with. And anyone who's been pregnant, I know you guys have, we all within the last 2 years, the three of us, but it can be very isolating sometimes. So I can imagine that this makes a big difference for patients who are feeling that, or maybe who, don't have other people in their life. Maybe they're the first sibling in the family to have a baby. So I could text my sisters all the time about hey, what did you do for this? What, that kind of stuff. But if someone doesn't have that, if they're the first one in the family to go through it, or they're the first of their friend group or whatever, this is going to give that support system, which I think is really cool. Can we talk a little bit about, because I know there's a lot of negative rhetoric on social media about having a baby in a hospital right now, unfortunately. And I think there are a lot of misconceptions that then happen because of things that happen in certain places. And there may be legitimate systemic issues in certain places that women are routinely not listened to about their pain level, or they are routinely not asked about their preferences before delivery. But that's not the case everywhere. So can we talk a little bit about what is the experience, especially here? How do we make sure that patients are in control and are empowered throughout their delivery, their birth, their prenatal journey, all of that? Whoever wants to take that question.
I guess I can. So I went to a conference many years ago, and they said over 1 million women have some form of postpartum PTSD from whatever experience they might have had in different places. So with that, and with centering, when they get knowledge of things, so we might show in one session, hey, this is what a vacuum will look like for delivery. Doesn't mean we'll necessarily do a vacuum, but so you know what a vacuum is. This is if the C-section, if we were to talk to you about a C-section, it would be in these certain cases. This is what a fetal scalp electrode might look at, but we're not going to do that necessarily with everybody. So informing the patients of the tools that we have, but then when a situation arises, so let's say if we're noticing there's some decels on the strip, we won't ever just say
who's the what?
Sorry, baby's heart rate's going down on the heart rate, and we won't ever just okay, now we're gonna bring you back for a C-section. We always say, hey, we're starting to notice, the baby's heart rate's going down a little bit. Just if this were to continue, we might have to end up in a vacuum delivery or whatnot. But then the patient can decide okay, I hear you, but I don't know let me just think about this and
Yeah.
make my own decision. We're
Right.
never going to force
Give me a minute
a
to kind of
patient
think
to do
through.
anything.
Right.
And another misconception about hospitals is that they're going to come to the hospital and they're going to be tethered to the bed. You're
Oh.
not tethered to the bed. You have the freedom to move. We have the jet tubs. We have
Yes, they
we
were
have
awesome.
we have all
I
these
hung out for
tools.
quite a bit in that tub.
It's
so
nice,
was
yeah,
great.
and they're fancy jets too. So
Yeah,
which
it
is
was awesome.
great
And I was
too.
walking around. I mean,
You got
it's
portable
really
on
not,
it. You got portable, and the nurses are really great about helping with different positions and stuff too.
And most of them are
And-
doula trained.
And they're doula trained,
Yes.
and,
And
so,
lactation
which is
trained.
very
Which-
unique in my
yes.
experience.
Yes.
What about you guys? Is
Yes.
that, have you heard of other hospitals
No.
that have almost all of their
Mm-mm.
nurses and providers trained doulas
No.
No.
and lactation consultants?
No.
See, we're special here.
And
Which is why I
Well-
drove an hour to have my baby at Hillsdale. Thank goodness I
Yes.
did.
Yes.
Look at it.
I would say, to add to what Rachel's saying, we engage in something, this is sort of a new term, but in medicine in general, but we do that here. We engage in something called shared decision making. So no
Mhm.
decision is only on the doctor or only on the patient. We really, really value trust here between the doctor and the patient, between the midwife and the patient, the nurse and the patient. And so that relationship is so important, because when there is an emergency, when there are sort of gray areas in medicine, which happen a lot, like we could go this way or this way, we engage in that discussion. You know, I can speak as a physician. I'm here to tell you my medical opinion about something. I'm not here to force anything. And Rachel feels the
Mhm.
same. Everybody feels the
Mhm.
same here in the room. So we're here to tell you our expert opinion. And most of the time that's, you know, that's a really valuable thing, but that's not everything. So the patient's, you know, decision to, or their ability to make decisions based on opinions is so important. So we inform them, we tell them about risk, we tell them about benefits, we tell them about possible outcomes, what may or may not happen, what the chances of that happening, give them as much information as we can in the way that the patient can understand. Depending, they might be a medical person themselves, they might not be medical.
Mhm.
And then we come together and make a decision. Is a C-section the right decision? So nobody's walking in and saying you have to have a C-section, you know, or you have to have a vacuum delivery. Hey, this is what we're seeing. Let me tell you what that means to me. And here's how we can make that decision together. And so I think a lot of those conversations are happening. And I think in, you know, especially labor and delivery has gotten bad rapport. And like you said, in some places, especially historically, because if we look back historically, it was more of a model of this is what you're going to do and this is why you're
Right.
going to do it. And then the patients just do it. But now it's a lot more of that shared decision making. And we, as sort of a new generation of medical providers, really value that, and really encourage our patients to be a part of those decisions. Now, of course, there are always times when there are extreme life-threatening situations and we may need to make a decision for a patient if they're incapacitated, unable to make decisions for themselves. But those are rare and far between. Mainly this shared decision making is just, it's a great thing. And I think centering is going to help us do that even more, because as the patient, you're going to be able to speak with us more, build that trust more.
You'll have so much more FaceTime with you guys as providers.
Before something happens. And honestly, most of the time, labor and delivery, things go great. And we have, you know, birth plans we support our patients have birth plans. We support that. And a lot of times we are able to meet those expectations. But when we're not, shared decision making is just a great model of care for our patients.
Right. And I would say for patients who, because sometimes I think people bring in maybe what they've seen on social media, but also their own past experience, right?
Yeah.
I had my first baby at a different hospital. It was a good experience. It was, I mean, well, it was fine, but this experience was amazing. Yeah. But if someone is coming in as a patient to our practice that has had an experience before with their pregnancy or with their labor and delivery, where there was a bad situation with a provider or where they just did not feel listened to, or they have some of that trauma in their past experiences, how would you recommend that they approach that with you as their providers from the beginning so that you can give them the best care?
I mean, I think asking questions, you know, like it's up to we have to view this as a relationship. So We ask things like, are you planning a vaginal birth or a C-section? Tell me about your last, births. And in that, we hope to establish this relationship and this trust where the patient can tell us, like, maybe I felt sort of pushed into that last C-section. And then we can, that's our opportunity as the doctor, as the midwife, as your nurses to say, okay, well, how can we make that experience better for you? How can we help you get to your goals? How can we assist you? How can we talk to you in a way that's not traumatizing? So it's just really important that we discuss all of those things. And I think that without that trust piece, without that relationship piece, we're really unable to do that. But I think by, maybe a patient says, well, I felt maybe pressured into a C-section, we can say, well, this is how we do things here. We're going to always engage in shared decision making and kind of not say, oh, we don't do that here, but just what are our processes? And sometimes the truth about what we do makes patients less anxious about their next delivery. We're not in a big practice where you have 12 doctors and you're not going to meet the one who's delivering you. We have a relatively small practice, even though we've expanded. And so all the patients should be able to meet the person who's going to be there for their delivery and talk to them about their fears and their concerns. And centering definitely is going to give more of an ability to have that conversation. Even if you're not willing to say it yourself, there's probably somebody in your group who's going to bring it up.
That's a really good point. That if you're thinking about that, but you're not really comfortable talking about it, you're probably not the only one in the room that's had an experience like that. That's a really great point. So let's just go back and summarize in its most basic form. If a patient comes in and says, hey, someone told me y'all are doing some new thing with prenatal care, what is it? What's like the 30-second elevator pitch for this is what centering is?
Centering is a model of prenatal care where it's done in a group setting. You're with other ladies around the same gestational age, about 8 to 10 of you guys. You'll meet every month until you get closer, and it'll be every 2 weeks. And there'll be a lot of group discussions and activities in the groups.
So you don't have to go through your prenatal journey alone, with this experience.
And also you can bring your partner.
Yes.
And also this is a proven model, not only here in the United States, but across the world. So this is not like something that we invented.
It's not an experiment.
It's not an experiment. This is actually evidence-based midwifery model. And it decreases the risk of interventions in your pregnancy, like Rachel was saying, medical complications, improves community, improves communication. Partners are involved because partners are the other half. We joke as women like, oh, we're the ones doing all the work with the pregnancy. And in some respect, that's true. But a really supportive partner is also there by your side, supporting you, helping you, during your pregnancy, postpartum, with breastfeeding maybe, or feeding the baby, however you choose to do that, helping you through postpartum depression. So actually the partner is just as important as our pregnant patient. And so including the partner in that, and then, it gives the opportunity for the partners to see the things we talk about, like depression, anxiety, and normalize some of those things that are kind of hard to talk about because it can happen to partners too. Mood disorders around pregnancy can happen in the partner, not only in the patient.
I actually was just, because I was cleaning out my home office the other day because it became Tommy's nursery because we moved him out of our room. And I found that spiral bound book of like the first year of pregnancy that I took home from the hospital. And I was like, oh, I probably should have read this 7 months ago. But that was the first time I had seen the paternal postpartum depression. Is that how it's described?
Yeah.
I had never heard of that, ever. So how common is that?
We don't really know because we
no
don't
one's
see
heard of
those.
it.
Well,
because
because
probably talks about it.
no one talks about it and no one documents it. So nobody follows up with let's say with the father of the baby in 6 months or a week or 2 weeks after.
Check in on them.
No one checks in on them. That they're just expected to do well with the transition to having a brand new baby. Their partner who just had a baby, so we don't know. But it definitely is. It definitely happens probably much more frequently than anybody even knows.
Yet another reason to do a program like centering because it gives the opportunity to talk about that, and it gets I think for pregnancy is isolating for the person who's pregnant, but also for the partners it can be.
Absolutely.
And so for them to be able to make connections with other people who are doing what they're doing and supporting their pregnant partner, I imagine is also very helpful to them. So what else have we not said yet that we want to say about either centering or our practice in general, the birthing center?
I think one thing that this will help with too is, in our practice is really good at, is looking at the patient as a whole.
Yeah.
And we've gotten away from the term of like non-compliant. I feel like
because it
there's a
assumes
reason.
intent.
Yes,
Non-compliant
there's a reason.
assumes that you are choosing not to be compliant, not
I just
you
can't
don't have
just-
transportation and haven't been able to pick up a prescription, for example.
Yes. So I feel like this is really going to assist in diving into the patient's whys of why they can't get to care, why they might not have running water at home, they might not have electricity, there's a lot of things. So partnering with the community and being able to bring in those resources right to these visits is going to be huge for our patients to have those resources at their fingertips.
And along with that, like there's a lot that the patients can help themselves with. That sounds silly, but people as in general, we build relationships with each other and we want to help each other. And that's the same thing when our patients know that we're all pregnant at the same time. And let's say in a specific group, they're going to help each other. So they might help each other with rides. They might help each other with childcare. They might help each other with just, maybe some talk therapy that they might need throughout their pregnancy. And then the community will be able to come in and we're going to invite them in. There are a lot of wise people in our community to help give sort of advice or help to our patients. So we're also going to be able to include them in some of those visits.
Okay. Anything else before we take questions? All right, Kirsten, do we have any questions from the audience today?
I have one question. Is there any update on visitor restrictions?
We have opened back up to our normal visiting. So as long as you are age 12 and above, you can come visit siblings. That doesn't matter what age that siblings are. So visiting hours are 8 to 8. We try and comply with that so mamas can get really good rest. But we are back.
Great. That is great
As
news
long as
as
you're
well.
not sick.
Yes, right,
Please
right.
don't come if you're sick.
Right. All right. So with that, first I want to thank all of you for being here today, for putting this program into practice. I know it is a ton of work to do this because it's a very different model just from how we function day to day in the clinic, especially. So I appreciate that. I know our community members are going to appreciate that as soon as they experience it. So to close today, we also want to thank you, our community, for your continued support of Hillsdale Hospital. To nominate a staff member for our quarterly patient care award based on the experience you or your family had, visit hillsdalehospital.com/award. If you want to support our capital fundraising campaign for patient safety equipment, you can go to hillsdalehospital.com/campaign. And to learn about volunteering here at Hillsdale Hospital, visit hillsdalehospital.com/volunteer. There's a pattern here, right? And if you want to join an award-winning workplace in the healthcare industry, check out hillsdalehospital.com/careers for current openings. We do have lots of opportunities everywhere from entry level to high levels of training and certification. We have opportunities here. And also I want to encourage folks that healthcare is one of the best industries you can be in to get on a career ladder, to be able to advance your skills and experience over time, where you can come in entry level. And a lot of times we end up covering the cost of your education to advance your career, to get a certification, to go to school, all of those things. So it's a really great opportunity if healthcare is something you haven't considered before, or if you know someone in your life who hasn't considered it, but might need to start thinking about that. So also happy Nurses Week, by the way, to all of our nurses out there. So it is Nurses Week this week. Next week is Hospital Week. So we are, of course, celebrating and recognizing all of our wonderful nurses here at Hillsdale Hospital. And then lastly, catch us on, not lastly, I've got 2 left. Catch us on WCSR on Fridays for more discussions like this. Don't forget to check out our national podcast, Rural Health Rising, at ruralhealthrising.com, or subscribe wherever you get your podcasts. So we will see you here again next Wednesday. And until then, stay safe, stay healthy, stay Hillsdale strong, and choose Hillsdale first.